Hello, Ansman.
Hi.
Nice to see you.
Yes, same here.
So, thank you so much, everybody, for joining us today. We're going to be talking about dysfunctional uterine bleeding. I think this was a topic we spoke about last time as an interesting topic.
Yeah.
Because I guess as GPs, we do see quite a lot of this in general practice and common presentation. So, shall we start?
Yes, Zainab. So this I think this is a very relevant topic, pertinent also, because it's kind of very common presentation in our everyday clinic.
Yeah.
We definitely have one or two patients presenting for the first time saying there is some abnormal bleeding. And
Yeah.
then it starts from there, and then we always have to do the consultation. And the thing about it is it is never completely managed in one consultation, so
Yeah, absolutely.
it's just a start. So you have a good experience dealing with this, and also the you have done the diploma. So I feel you are the right person here to talk about it, how to approach when you get a patient, and what are the things to keep in mind and look for. So take
Yeah.
you through the journey.
Well, I have to say that, obviously I'm an independent clinician. Everyone does things differently. So what I'm going to say, or, my opinions are not 100% generalized. There might be some people who might sort of do something different. But when it comes to dysfunctional uterine bleeding or abnormal uterine bleeding, I guess that's the term we should be using, because even on EMIS, I don't know if you've noticed, you can't really put in dysfunctional uterine bleeding. It changes it to abnormal uterine bleeding. And I guess what we need to consider is when the woman comes in, what it is that she's coming in, why is she coming in now? The history is so important. We'll talk about that in a second. But firstly, just knowing what a normal menstruation cycle is, what is not considered normal is bleeding every 21 to 35 days, and it mustn't be excessive. Normal duration of a bleed is 2 to 7 days. So an abnormal uterine bleed is where the frequency or the quantity of bleeding differs to that woman. So they say, if the textbooks say, it has to differ from that definition of the frequency and the frequency of bleeding and the amount of bleeding. But actually, what is what the woman considers to be abnormal for her? So it's important to think about that. And that's where the history taking comes in as well. And there are so many causes, and that's why it's such a huge topic, because each cause has its own massive, flow chart. So do you have any questions so far?
Yes. So I understand it's a like huge thing, like a lot of things to consider. But would you like to take us through, like, for the first timers, like, what are the things not to be missed in the history questions?
So obviously, with regards to if a woman who's postmenopausal comes in with bleeding, obviously that's a big red flag. So they need to be referred on the 2-week wait. So that's the biggest thing. The other thing is to think about, actually, that question's quite difficult because it depends on the age of the patient. So if a young girl's come in, she's just recently started her period, it's quite normal to have irregular bleeding at that point. And also, if a woman is reaching the end of her reproductive life, like, that also up to 5 years to the point of where her periods stop, it's quite normal to have irregular bleeding. So as long as everything else has been ruled out, you can consider that to be okay and normal for her. But the way that I approach it is think about, is it an ovulatory problem? Is it a structural problem? Also, when it comes to medication, having a look at the medication. Are they taking hormones already? Are they on any anticoagulants? Also, chronic health conditions like thyroid problems can cause problems with menstruation as well. Are they under any emotional or physical stress that could possibly cause them to have irregular bleeding? For example, if they're excessively exercising and losing loads of weight, that can make their period stop as well. or if they're putting a lot of weight on, maybe their periods are going to get more heavier and more frequent. And the other thing to consider as well is pregnancy. You know, you don't want to miss an ectopic pregnancy, and you don't want to miss someone having a miscarriage. I think that's quite important.
Hmm. So, is there any time period that when someone presents, like sometimes we see patients presenting just with one episode, say, oh, you know, there is a, you know, I finished my periods and then I started bleeding. So
Okay.
is there any criteria, like, okay, it is like, say, 2 months, 3 months or something like that?
Are you talking about women who are reaching the end of their reproductive life?
No, generally,
No.
someone presents with, like, I have a normal bleeding. So sometimes I have come across patients who have just, okay, this period and it never happened before. So,
Mm.
it, you know, finished my periods and then after 8 days, I started bleeding and
Mm.
for like 8-10 days. So is that something?
This, yeah, this is where taking a really good history is so important. So when you first start taking a history about period, make sure you find out what is normal for that person. Exactly. When do they have their period? Is it regular normally? Is it irregular? Also find out about what they've been doing. Was it after, what happened at the time of bleeding? Did it happen because of something? Number one, find out if they're pregnant or not. That's one thing. Always do a pregnancy test. The other thing is, could they have an STI? So if they're sexually active, does the bleeding start after intercourse? How much is it? Is it spotting?
Mhm.
Full bleed? Is it just discharge? Because bleeding can mean different things for different women. So it's important to quantify that. And that way you can try and sort of narrow down what the cause could be. And also hormonal changes as well, if they've been under a lot of stress. Are they on contraceptive already that's causing the problem, like POP, for example?
Mhm.
Mm.
Okay. Okay. So, so what are the main differentials that we should keep on our mind?
So I guess we need to, when we think about ovulation disorders, like I said, if we know what the normal menstrual cycle
Mm-hmm.
entails, then you can work out maybe what's going on. So if they're not producing enough, if they're not producing enough FSH or LH, think about a pituitary problem, and they may need further investigation down the line. Maybe check a prolactin level, for example. Structural issues can be found out via ultrasound scans. So things we need to think about are polyps, fibroids, adenomyosis, also whether they've lesions in the cervix. Are they old enough to have a cervical smear? So if they're not, then could you still examine them? Also scar tissue or IUD. So these kind of differentials are quite important. But it does really depend on the history, because you got to find out if it's painful bleeding, is it painless bleeding, how much is the bleeding?
Mm.
Yeah.
Okay. Uh, so, so after you get through the history, so how much role the examination has?
The examination has quite a bit. It's more complicated if they're still bleeding, because you want to have a good look at the cervix. I mean, the examination, I guess the first thing you can do is an abdominal examination, because you want to, number one, find out if there's any other symptoms like abdominal pain. The other thing I didn't say was PID as a possible cause as well. So they might describe fever or abdominal pain, discharge, that sort of thing as well, and pain on intercourse. So examination wise, you would do an abdominal exam and also PV, looking at the cervix, also do a bimanual to check for adnexal tenderness. That plays a huge role. And then, you can see if there's any lesions that could be causing the bleeding at the same time. But I think eventually, ultrasound scans are quite good, because they give you more information about whether there's a structural problem there as well. So.
Hmm. Uh, no, I just deviate a little bit. When you say ultrasound scan, I
Yeah.
always try to think like what which way I should go, like transabdominal, transvaginal, or both.
I think I think actually transvaginal gives you more information, isn't it? And it depends on the woman as well, because sometimes if they have a high BMI, transvaginal is probably better in that situation. But generally, I mean, they tend to do transvaginal for checking for uteral abnormalities, don't they? I don't know if you've noticed.
Mm-hmm.
Yeah.
So I sometimes tend to request both.
Do
So
you? Yeah.
yes, so
Yeah.
just, do that, because um, I I sometimes struggle to think like, okay, which one would be more beneficial. Now you explain that transvaginal would be more
But
beneficial.
also, I mean, some women don't expect that. So I think it's so important if you are referring them, isn't it, to tell them that if they might do a transvaginal, because it's
Okay.
quite uncomfortable for a lot of women don't find it very comfortable and sometimes complain of a lot of pain afterwards. So yeah, so if anyone is going to refer for transvaginal, definitely explain that to the patient.
That's very, very useful piece of information.
Mm.
Yes. So the bottom line is, whichever investigation you are requesting, explain to the patient clearly that this is the investigation I'm requesting, and this is
Yeah,
you should expect.
absolutely. Yeah,
Mhm.
and then they can always, if they decline it, then at least you know why, and that sort of
Yeah.
thing. Any other questions on someone?
Yes. Apart from ultrasound scan, any role of any specific blood test?
So there are hormonal tests you can do with prolactin level as well to find out if there's any pituitary disorder. And some people do request FSH and LH as well to check whether there is any ovulatory issue going on. FBC, if they're having really heavy bleeding, I guess that's quite normal to request a full blood count to check for anemia. I think anemia is a huge issue if you're having heavy bleeding, so because they might need iron as well. So
Mm.
they're the main ones I can think of. I don't know if anyone on here can give us any other blood tests that you've requested as part of this kind of workup.
Uh, what I tend to do is, sometimes you get a history that the bleeding is heavy, like, and a lot of times we ask about how many times you are changing pads, so that gives us an idea.
Yeah,
So sometimes I come across history where it says like, okay, um, you know, um, 7 8 days of bleeding, and then changing pads every half an hour. So,
yeah,
and then doing the bloods, especially looking at hemoglobins, that would give us an idea. Like, every individual is different. Like, looking at the bleeding, they might think, oh, this bleeding is huge, or
yeah.
some other may think with the same bleeding, it's okay. So when we do bloods, I feel we have a better idea of how much in
How
history.
much is the blood loss? Yeah,
Yeah.
yeah. Ferritin as well. Yeah.
Yes.
So I guess I tend to do that when I do when you do full blood count, you automatically sort of do the ferritin and
Yes,
transferrin
the
level. Yeah,
hematinics.
that's great. Yeah,
The hematinics, yes.
yeah,
So those are also important. So
yeah.
any role of CA125?
That's a question I didn't even think about actually in that sense. Um, I don't think so. I don't
Okay.
know what other people think about CE125. Generally, the symptoms are a little bit different, and it depends on the patient. It depends on, I guess, their age, but not always. It depends on the other associated symptoms. If they are getting bloating, loss of appetite, they've got other symptoms in the mix of that, then I probably would add it on, but not always. And also it depends on the ultrasound scan as well, if they've had any lesions there or any cysts there that may, then I'll probably request a CA125.
Mm.
Yeah, so in your experience, how common is DUB for patients on warfarin? I mean, I don't know how common it is because
Mm.
not a lot, I've not seen many women on warfarin with DUB.
Mhm.
Have you seen anyone?
Not really, no. But in the history, we exclude that, don't we? That we ask, like, any coagulopathy,
Yeah.
family history of bleeding disorder, and we look at medications. So we try to exclude that. Of course, it is something that we would not want to miss.
Yeah, absolutely. And I think in that situation, you probably would ask for gynae advice as well if there's anything else we can do in that
mm,
situation.
mm,
Yeah.
mm. Um,
So,
I have
yeah.
another question. Like, okay, so we did the history, we did the examination, and in the examination you said abdominal examination is very important, as
Yeah.
the bimanual PV and the speculum examination.
Yeah.
And then you told us about the blood tests and the ultrasound scan. Now,
Yeah.
um,
I
so
forgot to mention actually, Unsuman, swabs as well.
okay,
So you would do swabs if in the surgery you've got that opportunity to do a chlamydia swab or just general, swab. Then we tend to do that,
hmm,
just in
okay.
case there is an infection there that could be causing the bleeding.
So this is kind of genital MCS.
Yeah,
Okay,
yeah. But
I,
we do have chlamydia swabs in our surgery, so we tend to use them as well
I
at the same time.
mm. So so in the meantime, while we are doing it, so it takes time. Like history examination, okay, done, then investigation. But if there is a patient who says ongoing bleeding, so what do we do in the interim when we are waiting for all this to come back?
I guess as long as you've ruled out any contraindications, you can give them the pill to sort of stop the bleeding in the meantime. As long as you've ruled out that the bleeding isn't anything serious. Is that something that answers your question? I think that's probably what I
Yeah,
would do if they
yeah,
have ongoing bleeding.
hmm,
It's difficult to examine patients when they're bleeding as well.
yeah,
So, but I would probably eventually the bleeding may stop. So you might ask them to, while we're doing the full blood count, wait for that, and then maybe start the pill if we think that actually it's okay. There's no contraindication there.
hmm, okay, okay. And what pill would you
I would probably do norethisterone, something like that.
okay?
Help stop the bleeding. That's the same pill that some women use to stop their periods when they
Yes.
go on holiday and things. So that's
Mm,
the one that I would use. I don't know if anyone else. I know we've got a few GPs on here. If anyone else has used any other pills, that would be quite useful.
mm. And how long can we use that?
So from what I think you can use it for about 10 days, can't you? 3 times a day, 5 milligrams.
Mm,
And then you stop it, and I think you do get a bit of a bleed afterwards.
mm, okay.
Yeah.
Mm. Uh, okay. So we did the interim, and then investigation results come back and say we don't find patient anemic. All the other parameters are fine. So what could be the outcomes of ultrasound scan?
How do you mean? So if someone's had, so we don't, it could be anything though, isn't it?
Yes.
Um, I suppose it could be a normal
So
ultrasound scan a lot of the times.
let me clarify a little.
Yeah, clarify
So
it.
confusing question. So what
Yeah,
was so there could be two outcomes, right? So one
yeah,
is normal ultrasound,
yeah,
and the other one is they might find.
abnormal. So
Of course,
I think of the structural problems that you could have. So like fibroids
yeah.
or, yeah. So you have to think about fibroids, adenomyosis,
Hmm.
uh, whether they've got any sort of other endometrial deposit in it. That's normally with laparoscopy, isn't it? You gold standard investigation on normally, or polyps might be seen on there, polycystic ovarian syndrome signs, and maybe they've got cysts on their ovaries, that sort of thing. They're the main ones that I can think of.
Okay. So what I was trying to get at is the next step after if this goes on, and
Yeah,
in spite of say we did not testosterone that helped, then we stopped, and the,
the
by the
bleeding's carrying on.
patient's
Yeah,
patient says no, it is actually going on, and actually that can bring them down. Like
absolutely. Yeah. It's
yeah,
so important though, and someone to think about the woman like holistically, not just with regards to the bleeding.
yeah.
Basically, because the bleeding can be affected by emotional, physical stress, like we said at the beginning. So it's important to clarify what's going on in that woman's life, the situation, and then we can decide how we can help. I mean, obviously, gynae are always on hand. You can always ask for advice and guidance with regards to the ongoing management. If someone is coming in with persistent bleeding that's going on and on and on, then yeah, they probably do need to be seen by gynae. If the ultrasound scan is normal, then you probably think, actually, if there's no other cause, I would probably check prolactin in that situation as well, any other bloods, just make sure the bloods are checked again. And then I'll probably ask them if they want to go on the pill, or even if there's no contraindications, the Mirena coil, or something like that, to help minimize the bleeding or stop the bleeding. I guess the other thing is endometrial ablation. If fertility is not an issue, they're not looking to have any more children, some women do opt for endometrial ablation if they have issues with bleeding as well.
So can I then say that after the investigation, if the bleeding is still on, like say either continuous or intermittently, then the next step is definitely a specialist referral, either in the form of advice and guidance or a referral?
I probably would do that, because if when the patient's probably not going to be very happy, because they're probably thinking the investigations are all fine, I'm still having this ongoing bleeding, so then I probably would do that, would ask for the advice and guidance, and maybe ask them if they want to take the pill or go have the Mirena coil if there's no contraindications. When do you investigate DUB, or do you decide based on patient's age and risk factors for CA? So we tend to investigate pretty much straight away, don't we, if someone comes in, and risk factors for CA, I guess, if DUB happens after the age of 50 and they're postmenopausal, then yeah, we would send them on a 2-week wait. If we suspect an ovarian cancer, then we would send them on a 2-week wait. And if there's any history, anything on examination, such as a cervical mass or a vaginal mass, or anything that would be causing the bleeding, that would obviously require 2-week wait as well. I don't want to say that the typical age of women who get cervical cancer are young, or it can happen at any age, isn't it? So it's important to do the full investigation history examination on every woman that you think needs it.
Yes. So okay. So this is the general approach for a woman presenting with abnormal bleeding. So would you like to share your experience or discuss some scenarios so that?
Yeah. So well, I mentioned that book that I had that I used for the DRCOG. This one. Yeah. So there are some scenarios. I don't know if people, whoever's on now online, can actually join in and give us the answers they think are the right ones. So the first question: Anneli Paris, 22-year-old woman, presents with a 4-month history of intermenstrual and post-coital bleeding. She's healthy with no other medical problems and is using the withdrawal method for contraception. Select the most appropriate investigation. So the sort of answer options are, if I try and do this, I don't know if it'll work, but let's see. It might not work. I don't know if I can do this. It's probably not very clear, but cervical cytology as A, B, endocervical chlamydia swab, C, hysteroscopy, D, pregnancy test, or E, transvaginal ultrasound scan. Which one would you go for, and someone in that scenario?
Chlamydia swab?
Yeah, I think that's actually the right answer. Let's see. Yeah, that's actually the right answer. So obviously, she's a young girl. She's 22. Very short history. So it's quite important to do a swab for chlamydia, because that would be the most appropriate investigation at this point. When I was looking at this, I thought cervical cytology. She's 22. She's not going to be old enough in England to have a cervical smear. Hysteroscopy, does she really need that at this point? Pregnancy test, possibly that as well. And transvaginal ultrasound scan, possibly. But the first thing is probably doing an endometrial endocervical chlamydia swab. Karim's asking why not pregnancy first, because she's had a 4-month history of intermenstrual bleeding and postcoital bleeding. It's likely, it's quite common in chlamydial infection to get contact bleeding. So that's one of the first things you would do. And then, yeah, pregnancy tests would be on the card as well.
Yes, but 4 months, if someone is bleeding because of pregnancy, 4 months, by 4 months, it would be obvious. I mean,
Yeah.
it would be obvious, yeah.
Yeah. And obviously, you know, the next question, an 18-year-old student is referred to gynecology clinic because she has experienced increasingly heavy irregular periods during the previous year. So her menarche started at age 14. So basically 3 years of normal periods and then 1 year where it's become increasingly heavy and irregular. Her BMI is 38. Abdominal examination is unremarkable. She declines pelvic examination because she is a virgin. So select the most appropriate diagnosis. So the options are, so I'll just put this behind there for a second. Let me see. I don't know if I can get it clear. Oh my God, this is so bad. A, anovulatory cycles. B, pelvic inflammatory disease. C, PCOS. D, thrombocytopenia. E, von Willebrand disease. What do you think?
I'd go for PCOS, but
yeah, that is actually the right answer.
Yeah,
and I think
BMI
for me, it's like certain details in the history that make me think that her BMI being 38, I think that sometimes makes you think of PCOS. But there are women who are not overweight or obese who do have PCOS. But so it's not a generalist thing, but generally in examinations, they tend to do the most obvious. Yeah, that's right. You got it right. And on anovulatory cycles do cause irregular bleeding, but tend to be, it would have resolved by now in her because it would have been at the beginning of her period starting. So it can't be that. Pelvic inflammatory disease, so she's a virgin, she's not had intercourse, a bit unlikely. And if she had any blood disorders, then she probably would have been found out earlier in her life. So yeah, so PCOS is the right answer. Okay, so the next one, the next is quite a few of them, but I'll just there's a list of extended matching questions. So I'll put it up in a second, but I'll say the first one first. So a 22-year-old student with an 18-month history of non-cyclical, intermittent lower abdo pain and deep dyspareunia. She is tender in both adnexi and the uterus is retroverted. So have a look at the options that we've got here. Let's have a so, oh God, it's not very clear. So here we go. If I can move this like that. So we've got adenomyosis, appendicitis, chronic PID, endometriosis, interstitial cystitis, IBS. So we have got one answer, endometriosis. I'm just going to read the question again, just to a 22-year-old student with an 18-month history of non-cyclical intermittent lower abdo pain and deep dyspareunia, and she's tender. I guess endometriosis is a possibility, but it's non-cyclical, the pain. So actually, what do you think it is?
Chronic PID?
Yeah, that is the actual answer. So chronic PID here, only because it's non-cyclical. In endometriosis is usually cyclical pain. So just to remember that. The next question, I'll keep that up. As well as experiencing dyspareunia for 6 months, for 6 months, a 48-year-old woman has pain when her bladder is full, which is associated with urinary frequency and nocturia.
The urinary frequency and nocturia, and this is going to be, I'd say, ovarian CA would be my differential, but there is no.
No, it's not on there. So I'll read it again. So she's got deep dyspareunia for 6 months.
Yeah.
She's 48. Pain when her bladder is full.
Yeah.
And has urinary frequency
interstitial cystitis.
Yeah, absolutely. Yeah, that's it. And then the next one is anyone else? Anyone else have got interstitial cystitis on that one? Cyst, yeah. So there's quite a few. You know, they're so varied, aren't they? I mean, here in the question, they said interstitial cystitis produces pain that is always worse when the bladder is full and is often mistaken for endometriosis and chronic PID. The bladder will be very tender on bimanual examination and is sometimes refractory to treatment. It is diagnosed at cystoscopy. So that's what you've got there. The next one is, after years of being on the pill, a 35-year-old woman has developed a gradually increasing severe dysmenorrhea, intermittent pelvic pain, and dyspareunia in her first pill-free year. On examination, her uterus is normal size and both adnexa are tender. So what are you thinking there? So she's a 35-year-old woman. She's been on the pill for years, and she's now developed. She's stopped taking the pill for a year, and since she stopped taking the pill, she's been having increasing heavy periods, pelvic pain, and pain on intercourse.
So that could be that could be endometriosis.
That's right, yeah.
Yep.
So what was happening was the pill was yeah, you're right, Kurum. So you're all right. The pill often protects women. The pill often protects women from the manifestation of endometriosis until they stop taking it. So she probably didn't realize she had endometriosis all that time. 2 seconds. I'm going to hold the paper like this a second. Sorry. I've got a couple. I think there's 2 more questions, guys. 2 more questions. So the next one is, let's have a look. A woman who has had 5 normal deliveries complains of increasingly severe secondary dysmenorrhea. Her periods are regular but becoming heavier. The uterus is bulky and very tender on pelvic examination. So what are you thinking from that list?
It's uterine fibroid.
Uterine fibroid. I would have said that as well. But actually, anyone else with any, what do you want to say, Kurum? What do you think? A cyst? Yeah, cyst is obviously, that would have been one of the ones. I was so stuck on this one. The answer is actually adenomyosis. And they say that because if the uterus is very tender on examination, that's the diagnosis, which is more common in multiparous women, and she's had five babies. And it causes severe secondary dysmenorrhea. If the uterus is irregularly enlarged, it suggests fibroids instead. So there we go. We'd have to do an ultrasound scan to confirm that. Sorry, I'm going to just look at the next question. 2 seconds is really bad. We didn't have PowerPoint. A 24-year-old woman has been using the pill since her teenage years to control her heavy periods as well as for contraception. She seeks help on account of intermittent pain in both iliac fossa associated with abdominal bloating and deep dyspareunia. Now, I got stuck with this one as well. What are you thinking?
Ovarian cyst?
No.
It is irritable bowel.
Yeah, and I think the things in the question that make you think that, you know, there could be a cyst is obviously the pain and the heavy periods possibly, but it's the bloating and intermittent pain, you know, that makes it more irritable bowel. God, let's bring me back. Okay. So how did that feel? A little bit of questioning. But it just shows that there's so many diagnoses that you can be thinking about and should be thinking about if someone comes in with, you know, abnormal uterine bleeding, and it's not just one thing, and you can't even make a flow chart. It's that complicated to try and say, okay, you're going to go that way, this is going to happen. If you go that way, it's just very, very difficult. So,
yeah, really interesting. Yes.
Yeah. I mean, the questions in this book are really quite challenging, I felt. Some of them are very obvious, but some of them do make you think, actually, I should be thinking about every minute detail. And that's why, you know, it's so important to do that when you're taking your history. Let me just have a look if there's anything else that we need to make sure that we cover.
I think a question there, that is IBS not a diagnosis of exclusion? Yes, but still we keep it in mind as a differential, and we're going for the most likely. And yeah.
So it's quite important to think about holistically the woman, just holistically everything. So has she got any other health problems that could be causing it? Well, maybe in the blood test when they come in with dysmenorrhea, maybe we should do a thyroid function. Do you do thyroid function? If a woman comes in with, so that's quite important. Yeah. And this obviously exclude pregnancy, ectopic. But I guess it's also important to let patients know as well that if they are coming with abnormal bleeding, that we may want to examine them, because I have had patients come in and say, "Oh, I don't want to be examined today," or they find it a little bit daunting. So, and or maybe having a chaperone ready if you know that someone's coming in, or maybe book it for another time so they're more ready, more prepared.
Yeah, my approach is definitely the blood tests and the ultrasound scan. Irrespective of what you find in the examination, you're going to do that anyway.
Yeah.
So the patient is not available, or these days some patients prefer telephonic, so you still request those investigation. So
Yeah, absolutely. Have you thought this has this been useful? I mean,
but
yeah. I know
I've
we didn't have PowerPoint presentation or anything like that. That would have been maybe, loads of pictures and things like that. But it's good to have a discussion as to what other people do. And I know that I've done the diploma, but I guess in some ways this topic is so vast, and it covers so much area of gynecology that you just have to go with what the patient's saying. Make your history has to be top to be able to just go down the route to narrow down the cause.
yeah
And if you're always stuck, always ask the gynae team for advice on choosing book if you're worried or if you're not sure about something. Because we're a team at the end of the day, we should be able to, we should be advocates for our patients, and give them the option that they can have some specialist advice as well. Not just from general practitioners. But we do deal with this quite successfully, I feel.
mm.
Mm.
Yeah, good discussion, Zainab. You touched most relevant points, and in general practice we get this so often that this should, I think, whoever watched in general practice or general practice training, this will act as a refresher,
Yeah,
so, which is really helpful.
yeah. Well, thank you so much to everyone who joined and the questions that we had. Does anyone have any questions before we go with regards to dysfunctional uterine bleeding? I think the next we're going to be. Oh, that's really good. Oh, thank you so much. I find cases useful as well. I think it's important to apply the knowledge, not just have someone lecturing you about something. So
Yeah.
that's really good. Thank you so much for that, Shaheen. The other thing I was going to say is next time we're going to be doing the diploma. We're going to be talking about diploma of elderly medicine. This is something that we were asked about before and on Facebook as well. So I think I have found someone who will be able to do that and join us live. On the next live, we'll have a third person who will be talking to us about, the diploma of geriatric medicine, what they did, how they did it, how they prepared, and hopefully that will encourage others to do it because we have got a very increasingly older population, so it'll be quite useful, I think.
Yeah, I think
Yeah,
so.
it's okay.
Yeah, thank you,
Well,
Zainab.
thank you very much, everybody. Thank you, Shaheen, as well for
And
contributing.
we are going to put up this recording for everyone to look at if they want, right?
Yes, absolutely. If anyone wants to have a
Yeah.
look, yeah, that's fine.
Mm.
Thank you so much, Ansuman, and we'll be back.
Yeah.
Yeah,
In a month.
in a month's time,
Yeah.
hopefully. Thank
Okay.
you so much. Bye, everybody.
Bye. Take care. Bye.